Hello. So she is a 29-year-old female who sustained a road traffic accident, and what you can see very evidently on the coronal sections is that MCL is totally disrupted, specifically from the tibial side. So the tibial side is totally avulsed. This is the region of the pes, but the MCL is basically avulsed from the tibial aspect, and there is a lot of edema at the tibial insertion of the MCL. So it includes both the deep and the superficial components of the MCL, and specifically it is a medial based injury. So this is falling into what is called as a KD3 classification, and you can very evidently see that the PCL is very nicely attached on the tibia, but on the femur side it is avulsed. So this is a PCL avulsion from the femoral side. So on the tibial side there is a very good insertion, but from the femoral side the PCL is avulsed, and also the ACL insertion on the femoral side is not very well visualized. You can see a lot of inflammation in the ACL region, and overall you can appreciate that the tibia is subluxating posteriorly. So that is all falling into a posterior medial based injury with MCL complete tear from tibia, PCL from femur, and again ACL from the femur. So these sort of injuries are very bad injuries. If you see here, you can see a lot of inflammation and edema on the femoral attachment of the MCL, lot of edema. Medial based injury, lot of edema on the medial side of the femur, which is evident, and these sort of injuries needs to be treated with multi-ligament reconstruction. But here in this case we are planning something different, and we are now focusing more on primary repairs of the ligament as compared to reconstruction. So we will be going ahead with a plan of repairing as much of the ligaments as possible. If the repair is not possible, we may go ahead and do the reconstruction. So our plan will be to do primary repair of the MCL on the tibial side, and if possible PCL repair on the femoral side and ACL repair on the femoral side. So if we can do all these three repairs, overall the patient will have a more anatomically preserved and normal sort of knee in the follow-up. So let's start the live surgery, and we will be dealing with each of these scenarios, MCL, PCL and ACL, one by one. Thank you. Everybody, this is a patient who is presented to us almost 7 days after a knee injury during an RTA. You can see that this is a very unstable knee, and there is a total opening of the MCL, almost like 40-degree opening of the MCL in full extension as well as the mid flexion. So grossly unstable knee. Predominantly it's a very unstable MCL, and you can see some little bit of posterior and anterior sag as well. So this is almost a KD3 kind of an injury. Gross instability, whole of the MCL is opening, and this also coincides with the features that we have seen on the MRI scan. So now we'll start the case with a diagnostic arthroscopy. And we can see that there is a serous fluid which is coming out. So now needle please. Needle please. Knife please. Sure please. So there is a little bit of hematoma. So we are draining the hematoma as the first step. Sure please. And then we need to just clear off the fat pad. One, stop. Sure, please. Top. So if you see here, this is the torn ACL and this is the torn PCL, okay? Grasper, please. Hold it like this, please. Sure, please. Just a minute. Just a minute, just a minute. So there's a lot of hematomas or hematoma that we are clearing it out. Grasper, please. Sure, please. Top. Grasper, please. So if you see here, this is the PCL. Can you appreciate this? RF, please. RF, please. RF, please. So this is my torn ACL, and if you appreciate, this is my torn PCL. Okay, and this is called as a femoral avulsion of the PCL. Okay, this is my PCL, this is my ACL. Okay, and this is my fibrillation. This is basically the tissue which is above it. Okay. Sure, please. Top. So this is my ACL stump here. This is my PCL stump here. Now, since this is an acute case, sure, please. Stop, please. And there is a significant opening on the middle side, you can appreciate. There is a gross opening, wide open MCL on the middle aspect. Sure, please. Top. So the almost grade 3 plus opening on the medial aspect. So grossly increased opening on the medial aspect. Okay. Any questions, Om? So you can see that the whole of the medial side is opening, and the opening is on the tibial aspect. So we can assume that probably the tear is from the tibial aspect. So this is a grade 3 opening of the meniscus. Okay. Now flex the knee. Now as we were discussing, nowadays we are very much into and we are very much pro repair of the ligaments. So what I am planning to do in this particular case is I am trying to do more repairs as compared to reconstructions, and probably that will give a more better sort of a biological healing to the patient. So I'll just repeat my diagnostic examination. RF, please. So this is my PCL femoral side which is avulsed. This is my ACL femoral side which has been avulsed. RF, please. Stop. Chalo. Top. So this is my femur side which has been avulsed. RF, please. Stop. So this is my PCL femoral side which has been avulsed. This is my ACL femoral side which has been avulsed, and the MCL is avulsed from the tibia. So this is PCL femur, ACL femur, and MCL from the tibia. So now I'll just expose on the medial side and do a good repair of the MCL as the first step, and after that I will try to do a primary repair if possible for ACL and PCL. If I am not successful with a good primary repair of PCL, I may consider doing a PCL reconstruction as the next step. So we'll just open on the medial side because it is a medial based injury. Knife please. Knife please. Knife please. So we'll just open on the medial aspect, and we'll open on the more on the tibial side because we know that here the injury is predominantly on the tibial aspect. Okay. Okay. Can you give me a stool to sit please? Tortilla please. इसको इधर पकड़ना. So now you can appreciate that the tibial side is totally barren. The tibial side is totally barren. Whole of the this is basically the MCL which is nibbled over here. चल पकड़ इसको. Hold it please. Up. Okay, so now, so this is basically the stump of the MCL. We need to identify. So what has happened is the MCL is avulsed and it has gone above the original insertion of the MCL. So here, if you can appreciate, this is my this is the level of my tendons, and this is the, so you can see that this is the level of my MCL area which is torn. Okay, so not non-tooth force se beta. So probably this is the region of my MCL, probably this one. I'll just make a little bit. So this is okay. So probably this is the area of the MCL which has been torn. Chalo. Knife please. 15 number knife blade please. 15 number knife blade please. So I'll just harvest the. So this is my tendons. Okay. So this is the area of the MCL that we are talking about. So probably this is the meniscus. उधर रखना, ऐसे रखना. ऐसे पकड़ना. हाँ. So probably, can you hold it like this? So now if you see, my MCL is right here. If you see, Knife then. Knife then. Kuch mat. So this is one layer of the. This is the one layer of the MCL we are talking about. चल लाइव ध्यान रखो. Nice this. So this is okay. Forceps please. Non-tooth forceps please. Okay, so this is one layer of the inner sheath. This is another layer of the inner sheath. अब इसको थोड़ा सा वेलगस देना. Give me the velgus. इसको यहाँ से पकड़ना. Just. So if you can see, this is my meniscus. Okay, and this is the meniscotibial ligament. Okay, so this is the meniscus and this is the meniscotibial ligament here. Okay, and we need to repair it here. Okay, relax a bit. चलो ओके जस्ट थोड़ा MRI दिखाना. परफेक्ट. चलो समथिंग वी आर गुड हियर. चलो सो इसको ऐसे रखना सो दैट दे कैन सी. दिख रहा है बेटा? यू कैन सी दैट. चलो 5.5 mm peak anchors. एक रुक. 5.5 mm peak anchor please. इसको छोड़ो. एक और देना. एक और रिट्रैक्ट देना. मोमेंट्स प्लीज. इसको जबरना ऐसे पकड़ना. Suction please. Suction please. Curate, Vinod. Curate and wash. So this is the area where it is denuded. This whole area is actually off the MCL attachment. Wash, curate please. Wash and curate. So we'll give a thorough wash here. 5.5 mm peak anchors please. Now a knife, artery, forceps artery knife. Knife please. Anchor please. इसको जरा knife देना. So this is okay. इसको पकड़ना. So if you can appreciate here, this is the anterior part of the MCL which is torn. This is the main meniscotibial attachment that is torn, and this is again a flap which has been torn. So probably we need to repair this one like this probably, and this one is the main issue which we need to address. So this is probably the main part of the MCL which we need to address. So that is okay. Chalo. Anchor please. Inserter 5.5 peak anchor. So here, because this is a cancellous bone, and we can see here, if you can lift it up here. So this is my tibia. Okay, which we can see till the back here. Okay. This is a semity tendon. You can see there. Can you lift it here? So if you can see up here. Okay, this is the tibia which is totally exposed. This is the semitendinous tendon here. Okay, this is the semitendinous tendon which is seen here. This whole portion of the tibia and the meniscotibial ligament have been exposed. This whole area has been exposed, and we need to repair this to obtain a good result. So we will be doing a meniscotibial repair. Hammer please, anchors please. So we will do it from posterior to anterior. We will put 3 anchors. Hammer please. Inserter please.
Inserter.
Hammer please. Second anchor. Okay. The second anchor is a little bit more anterior to it. Okay, so number please. So these are unloaded anchors. They don't have needles, non-needle suture anchors. So what we'll be using? We'll be using a vital suture to actually hold these into their position. Okay, wash please. Chod. Now, okay. So it's good here. Sure. So now you have to just hold it up like this in its normal place. Wash please. Please. First pass means stop. So now we will be using the first pass ST भी ले ले ST ले RT देना first pass ST please. So there are two ways. Either you can just pass them sequentially. So here if you can appreciate, this is the area of the semity tendon. You can appreciate the semi-membranosus tendon very well. This is a semi-membranosus tendon. Semi-membranosus. The downward will be the semitendinosus. And then we will be passing these sutures one by one with first pass ST. So this is our first pass ST suture device. Visual up. And we will be passing the sutures one by one using the first pass ST device. So this is the first one. Second please. Okay, so we have the first pass has been passed and we have repaired four of them. Okay. So we will be repairing them something like this. Okay. Second then. After that, we will be passing the anterior ones. So one at a time. Force bada. So now we have seen that we have passed all the four sutures here and here into their place. Okay? So we have passed these four sutures and these four sutures into their place. Okay? थोड़ा सा आगे की तरफ पुल करना पड़ेगा. Relax. So now, non-tooth forceps please. Non-tooth forceps please. थोड़ा एंटी और देना स्लाइड. So that is okay. Relax. This will close later on. This will be closing. चलो इसको एंटीरियर और देना. So now we will be closing the meniscotibial ligaments in this fashion. LR anchor please. So anterior drawer please, है ना? Full anterior drawer, and we are closing the anchors, the meniscotibial ligament first. So this is my first suture. Okay. This is my second one. LR anchor please. I have asked my assistant to pull a anterior drawer so that it is reduced in a proper reduced anterior drawer configuration, because there is a posterior sag, and with these sutures we want to correct the posterior sag as well. So these are my posterior sutures. LR anchor please, inserter please. So this way we have closed the meniscotibial ligament along with the meniscus into its place. Okay. And now there is a posterior layer as well. So this is the posterior layer. Non-tooth forceps please. Now this is the posterior layer. I would like to include this layer also into my repair. So if you see here, non-tooth forceps please. Tooth forceps please anyway. So if you see, this is my important layer which I need to repair, because if I repair this layer, the first pass ST. So this is the posterior capsular layer which also needs to be repaired. So what I'll do is I'll pass my wire into this also. So I'll pass my wire into this. So that will help my repair. Blue one please. So this first pass ST is a rotator cuff repair device, but this works very well in this scenario because we want to close the tissues properly. So here, just hold it please. And what I will do is I'll just close these sutures back into their place. Okay. So this closes my tissue very nicely. So this closes my tissue very nicely and appropriately, okay? So this is the first one and this is the second one. Okay? So by doing this, we are actually making them. LR anchor please. Okay, non-tooth forceps please. Non-tooth forceps please. Non-tooth forceps. So now we know that this one posterior part is also there. So first pass ST please. So this one will be included in this part. Hold this please. Pull it please. So, and this is the last part which are tying. So this is a posterior medial capsule basically, which has been tying nicely. So LR anchor please now. So we are almost done with our repairs. All the 4 things have been placed into its place. Now I'll put, leave it. Now I'll put my this here, and I like to repair this into a lateral row fashion here. Okay, so I'll put a lateral row anchor here. Anchor hammer, please. So this is my LR anchor, and I'll put 4 of these. 1, 2, 3 and 4. I'll put 4 of these into my LR anchor and then repair it anteriorly, because I want to repair my posterior medial or strengthen my posterior medial capsule. Okay, so that's okay. Pull it anteriorly. Give a posterior medial pull. Anterior drawer, please.
Yes.
And this way, what I'm trying to do is I'm trying to reducing all my. Hold this, please. Hammer, please. So in this way, we are actually doing a double row repair of the meniscotibial parts of the MCL. Okay? Leave it. Leave it. So this way, we are done with the. Leave it. So with this way, we are actually done with the meniscotibial part of the repair. Okay? You can see that this is very good. Everything is now into its place. This is the semity tendons. Now we are done with my MCL repair here. So we have done what is called as a double row repair of the MCL. So if there is a superficial ligament avulsion down, then we need to use a all suture anchor, something which provides a cortical fixation. Here it was a meniscotibial ligament rupture. So we did a procedure which is called as a for the cancellous bone by using a 5.5 mm anchors. Okay? Thank you. Now we'll focus our attention into the arthroscopy. Shiva, please. Shiva, please. So now we are into the intra-articular part. Shiva, please. Just move the direction towards me, please. TV direction towards me, please. Very good, thank you. Retriever, suture retriever, please. Stop. Okay, green retriever, please. So now, if you see here, we have this area of the PCL which we want to repair. Show them. Show them. Stop. Okay, just hold it like this from posterior to back, anterior. Very good. Thank you. Grasp, please. So you can see that this is my PCL. Okay, this is the PCL which is torn, and I'll be using my anchors to repair the PCL into its place. So this is my PCL. First pass ST ready रखना. And this is my ACL, and we will repairing the ACL in the end. Okay. चलो Bankard Osteonaut anchor for Bankard if you can. और X6 भी दे सकता है. चल X6 है, X6 खोल दिया. कौन सा खोला है? हाँ X6 वाला ड्रिल बिट देते हैं. So this is the PCL stump that you can see from here to here. This is the PCL stump which is avulsed. Okay, this whole of the PCL stump is avulsed. Osteonaut या फिर X6 जो भी है. ठीक है. Okay, so now इसको पकड़ना. Shaver please. Anchor please. Flex the knee a little bit more. Flex the knee one more. Just relax. Relax. So now one more flexion point. So now we are doing an unusual procedure. We are doing a femoral fixation of the PCL avulsion. So we are good here. Anchor डालो बेटा. So we are putting an X fix anchor here. This is Osteonaut X. Round counter please. Go. So this is an Osteonaut X anchor. This anchor is put into the PCL insertion. Take it out. Take this one out. Beautiful. Take this one out also. This one out also. So we are good. So we have passed the first anchor into its place. Okay. Just hold it. And we will be just doing a seesaw movement to stabilize or check the pull out of the anchor. So the anchor pull out looks good. Okay. Extend the knee a little bit. Tocar please. Cannula please. Tocar please. Cannula please. Green cannula please. इसको होल्ड करना. Okay, hold it please. चलो. So we are. So now we are using a first pass mini anchor device to pass the anchors. cannula पीछे लेना होगा. Through the PCL stump. So this is my PCL stump, and I put my passage. The first passage is done through the PCL stump like this. Okay. So this is my first passage into the PCL stump. It holds the stump well. Okay. Second, please, artery, please. Second anchor please. RF please. Hold this one. चलो so छोड़ो. RF please. So I'm just doing a little RF so that RF चलाओ. So little clearance of the tissue so that it is better visualized. Stop. Okay. So this is my PCL stump. Okay. This one is a PCL stump, and I'll try to go as inferior as possible with this one. little bit of anterior drawer will help. Green retriever, please. So you can see that there is a little bit entanglement of the suture. Green retriever, please. छोड़. So now you can see that this is good enough. This is good enough. Third, please. Green retriever. Okay, so we are grabbing one by one. We are grabbing the PCL one by one, okay? Anterior drawer, please. So that is good. So now we have three sutures which are grabbing it nicely. Fourth one. Green retriever, please. Sorry. Green retriever, please. All the three को हल्का सा pull करना. So when you pull it, relax. So you can relax. Like this. So looks good. Okay, looks good. Probably I'll go a little down. छोड़ दो. Green retriever देना उसको. ऊपर I have more space for one more to put. So I'll plan to go more inferior. Fine. चलो पास कर देना. इसको पकड़ना. So anterior drawer as much as possible. Anterior drawer maximum. So we are good here. So all the four sutures are now tied here, and we can see that they have reducing it well. Okay, Shiva, please just a minute. Leave it. No, so when you pull it, the anterior drawer becomes a little better. Okay, RF, please. Take RF, please. Stop. RF, please. Stop. RF, please. Stop. RF, please. We'll put another anchor X-fix. Flex it a little bit. Go ahead. Just a minute. Look here. Go ahead.
Take it out. Anchor, please. Take it out. Put it out. Pull it out. Pull it out. Slide, please. Look now. Show देना. एक रुक ना. चलो. पानी स्टॉप. नहीं पानी तो ठीक है और उसमें है रबड़. रुक जा. थोड़ा ऊपर डालना था अपना नीचे. देना ग्रास पर देना. एक ऊपर डालना था. एंकर देना बेटा वापस एक बार. एंकर वापस देना. एक और एंकर रख देना. इसको पकड़ो. रुक जा रुक जा रुक जा रुक जा रुक जा रुक जा रुक जा. दोनों क्लोज आए एकदम. इसको पुल करना बेटा इसको. हाँ रुक जा रुक जा रुक जा. ऊपर जाना था एक्चुअली. एक और देना बेटा. हाँ एक और एंकर देना. इसको निकाल दे काम कर. छोड़ दे इसको. पुट वन मोर एंकर. एंकर दे बेटा. इसको पकड़ना. ऐसे पकड़ के रखना. हाँ रुक जाओ. नहीं फ्लेक्स नहीं करना क्योंकि अपने को ना थोड़ा ऊपर डालना है. तो देयर आर 2 bundles of PCL. So slight flexion. Slight flexion. बस हो गया. इनफ. चलो गो अहेड. स्लाइड और एक और फ्लेक्शन कर दो. स्लाइड फ्लेक्शन वन मोर. नहीं रुक गया. एक कम कर फ्लेक्शन. रुक जा. Go ahead. रुक. जल्दीबाजी नहीं. रुक जा. फ्लेक्स. गो अहेड बेटा. रुक जा. Go ahead. Direction देखना. Go ahead. निकाल दो. Take it off. Tunic please. Tunic time. So this is good enough. Take it. Chalo. Cannula please. Seesaw. So this is good enough. Okay. So good. Extend please a little bit more. Relax. Relax. So the first suture was grabbing the posterior medial bundle. Now this suture will be able to grab the anterior lateral bundle. Okay. Hold this one. Yes, as much as possible. So we are trying to put a deep bite into the PCL here. Green native please. छोड़ दो उसको तोड़ मत देना. So now relax. Okay, so इसको पकड़ना. Just इसको पकड़. So now this one is my pulling thread. You know. So what I am doing is I am passing sutures through the anterolateral bundle, which is the main bundle of the PCL. Just pull it a little bit, one. Okay. So these two are through the anterolateral bundles. छोड़ दो. deep देना. Green retriever please. Anterior drawer maximum. You put anterior drawer. ये आया नहीं ना, निकल गया लगता है. कट थ्रू नहीं हुआ, निकल ही गया. कट थ्रू है, रुक दे. कट थ्रू हो गया. देना वापस देना. ब्लू वाला देना. छोड़ दे. लूज छोड़, एक बार लूज छोड़. ग्रीन रिट्रीवर. One more, last one. I'll tie the upper one first and then the lower one, okay? Green retriever, please. नहीं, उसको पुल मत करो अभी, पुल मत करना ऐसे. ग्रीन रिट्रीवर प्लीज. वो सब छोड़ देना बेटा. लीव एवरीथिंग. आरटी हटा दो, आरटी हटा दो, आरटी हटा दो, सारी आरटी हटा दो, सारी आरटी हटा दो. चलो, दिस इज गुड. इसको पकड़ो, इसको पकड़ो. सो वी हैव टूक इट फ्रॉम द अदर साइड. वही अपना पास पास. Pull it a little bit there. So this is the main block of your PCL, and we want to go deep in to repair it. Okay. Green radio, please. Just one. Green radio, please. So I'm just taking it out from here. इसको पकड़ना. रुक जाओ. So this is here. So you have a good. So cannula, please, and now we'll start tying it. Okay. ग्रीन रेट बीच में नहीं इसको रुक चलते कैनला पीछे करना वापस कौन सा रहा है This is one. And this is the other one. So leave it, please. So hold this one too. So now what I am doing is I want to repair the PCL now onto its place. So this is how I am doing it. So these are all suture anchors and very thin small threads. So we'll be just putting them one by one into its place. So this is an extended indication of osteonaut X anchor. इनको सबको खींच के रखना बेटा. इसको खींच के रखना. So now this is my first suture of the PCL. काटने का देना. So this is my first suture, and this actually reduces the PCL very nicely into its place. Okay. So we'll leave it there. बाद में काटेंगे. Cannula, please. Green radio, please. इसको करना. You are doing a anterior drawer, beta?
Yes.
बेटा पुश लॉक एंकर रेडी रखना अर्थेक्स. आया पुश लॉक आया.
पुश लॉक आप जे
पुश लॉक नहीं, ड्रिल ना पुश लॉक. ACL માટે ઓસ્ટિયોકેર નો LR है ना. थोड़ा ऐसे आना चाहिए. रुक बस हो गया that's it.
की ढील होगी.
एक कैनुला और चाहिए, पर्पल कैनुला बीजी चाहिए. ओके, छोड़ दो look at इसको. So we can see that now it is much more stable. Okay, and then just pull it in. Cannula please. Push lock please. चल छोड़ दे इसको, पकड़ो इसको, पकड़ो. चलो देना बेटा, इसको पकड़ना. कैनुला प्लीज, नाइफ प्लीज, कैनुला प्लीज, नाइफ कैनुला, नाइफ 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 दे. चलो कैनुला दे. इसको पकड़ना. रिट्रीवर बेटा, ग्रीन रिट्रीवर. ऐसे रखना. रुक जा. उनको खींचना पड़ा, वायर को खींचना. रुक जा रुक जा रुक जा. छोड़ दे छोड़ दे. काटने का देना, काटने का देना, काटने का देना. तो ग्रीन रिट्रीवर, पुश लॉक रेडी कर. चलो गुड हियर. चलो फाइन. ड्रिल पुश लॉक का. इसको पकड़ के रखने से. ड्रिल देना, पुश लॉक का ड्रिल देना. रुक जा. ऐसे डायरेक्शन लेना. हाँ हाँ, काउंटर देना, काउंटर देना, काउंटर देना बेटा, काउंटर देना उस तरफ से, अच्छे से काउंटर देना. हाँ गो. नहीं नहीं नहीं, निकाल दे निकाल दे निकाल दे निकाल दे. चलेगा चलेगा चलेगा. गो हेड. अभी स्लिप नहीं होने देना, डायरेक्टली जाना. हाँ गो हेड. इसको पकड़ना, इसको पकड़ना, काउंटर देना. हाँ गो. निकाल दिया, हो गया चलो। ठीक है, ऐसे ही रखना। पुश लॉक, push lock. So these are push lock anchor. Putting a push lock anchor. Pull. Pull this one. So this push lock anchor goes like this here. Okay. Hold this, okay. Pull the wire one by one, slowly. Don't put more force. Pull it slowly. Hold it. Hold the wires slowly. Hold it. Hammer, please. So this is the push lock anchor, and this will be used to do a double row repair of the PCL femoral avulsion. Okay, stop. Chodo, leave it. And then we'll just rotate it like this. Cutter, please. Cutter, please. Okay, so this we have done a good PCL repair. Okay, you can see. Stop now. The posterior sag is very much minimized. So leave it. So the posterior sag is minimized. It is stable. Okay. Now we'll be focusing our attention onto the ACL. Do loop in. So this is my ACL. ठीक है. Don't. Relax. Loop in, please. 2 loop in, please. Shiver, please. Water, please. चलो. Loop in, please. 2 loop in. Stop. And then we need an LR. So we can see that the PCL is very tight and tense now. We have done a double row repair using a push lock and 2 Osteonot X anchors. And now we will be repairing the ACL also. Shiva, please. Stop. So now, this is my first passage. And I'll use the insert, please, for the loop in. Okay, load it. What is the first one? Second, please. Pro, please. Pro, please. So you can see that this is my ACL stump. Okay, it's not good, but it is not bad also. In this multi-ligament scenarios, these are all bound to heal. Okay, इसको थोड़ा रूट किया तूने, गिर नीचे. So now थर्ड एक लूपिंग दे देना तो मेरा काम हो जाएगा. So now this is my, पकड़ उसको. So ठीक है, fine. One more, please. Pro, please. So now Inserter for LR. Just a minute. So this is okay. So put it in. So there are three loop-ins. They are holding it nicely. Now I'll be inserting my LR anchor into the footprint. ठीक है? Slight flexion, ज़्यादा नहीं. Slight flexion. Slight जल्दा नहीं. हो गया बस हो गया. That's enough. So this is almost good, I think. Go ahead. Counter. Mark. Full. Mark. Don't follow. Hit hard. Stop. Cannula, please. Retriever, please. कैनला थोड़ा पीछे लेना. कैनला पकड़ के रखना. इसको पकड़ना. कहीं फंस रहा है. चलो हो गया. डन. हो गया. चलो insert, load it. Now this is my LR anchor and I am loading the LR anchor. Hold it. Okay. So now, if you see here, okay. Flexion is there, Flexion is there. Counter, beta. Oh fuck. Counter, please. Counter, please. Maro. Hammer here. So now we have just repaired it nicely. Okay, hold it like this. Now at this point of time we can see the ACL is tensioned and we will be pulling the ACL. 1, 2 and 3. So all these 3 has to be pulled in tension now. And counter please. And I am inserting the LR anchor. Loose. Beautiful. Leave it. So now this is my LR anchor. So we are perfect. So this is my ACL, which has been repaired nicely. The posterior, you can see my PCL. Here I don't want to do an internal brace because it is already a multi-ligament focus. If it is a solitary ACL avulsion, I would have done an internal brace. Here, because it is a posterior PCL repair also, so I'm not going to do an internal brace. It's not needed. Cutting, please. Cut, please. So, as we discussed, we have done a contrary to the normal procedure. The standard treatment for this will be ACL, PCL and MCL reconstruction. But in this case, we can see that the ACL has been repaired very nicely, the PCL has been repaired very nicely, and the MCL is also repaired very nicely. So all the 3 things we have repaired primarily, and that is actually what is the contrary to the actual teaching. So if you want to do a MCL, ACL and PCL reconstruction here, it will be a major surgery and there are very high chances of arthropfibrosis going on. Here we have not taken any graft. We have done a primary repair of MCL, we have done a primary repair of PCL, and that is also a double row fashion. So you can see that we have inserted a push lock here. We have inserted 2 X-fix anchors here. do a double row classical repair for the PCL, and then we have done a knotless repair for the ACL. So different techniques we have used, but eventually we have achieved a good normal anatomical picture of repairing primarily all the 3 ligaments. So actually this is the contrary to what the book is teaching is, but follow my words. If you do this properly and if you do this as I have told, you will not regret. It is a very good procedure to actually repair the ligaments as compared to doing a reconstruction, because they are coming to you at the right time. So this lady came to me at 7 days of the injury, so she was actually at the right time where this procedure can be done. Thank you. You can see the MCL opening is almost not there. So you can see that the preoperative, it was almost a grade 3 opening. The MCL was going into gross laxity, but it is nothing there. Okay. Slight flexion. कितना टूने का टाइम? 90 से ऊपर हो गया. चल काटने का दे फिर. क्लोज ही कर दो इसको. हाँ. चल छोड़ दो. पकड़ इसको पकड़ इसको. सीजर देना. क्लोजर दे. फोर्थ से. मैंने इसलिए वो कराई क्योंकि कॉन्ट्रेरी टू द प्रॉपर है, लोग कोई करता नहीं है. एवरीबडी विल डू रिकन्स्ट्रक्शंस या फिर स्टेज प्रोसीजर करेंगे इसमें. द अदर थिंग विच इज रिकमेंड हियर इन इज ए स्टेज प्रोसीजर. चलो टूनी को रिलीज कर सकते हैं. आई थिंक कितना टूनी को एग्जैक्ट है?
तो ले जा. हो गया.
एक मिनट. क्लोजर करो. क्लोजर का ले लो पिक्चर. 3 weeks का immobilization and then mobilize.
Okay.
थोड़ा स्टिफ हो जाए तो आई एम हैप्पी.
लॉक्ड इन एक्सटेंशन है.
हाँ एक्सटेंशन. हाँ थोड़ा स्टिफ हो जाए तो आई एम हैप्पी. MCL इज स्टिल थोड़ा सा. सो दिस इज अ वेरी, तो इसमें स्टिफनेस आती है, सो दैट इज गुड फॉर अस एक्चुअली. सो वी आर डन एक्चुअली. ठीक है छोड़ दो इसको. ऐसे पकड़ना. बस ठीक है छोड़ दो. ऐसे करके रिपेयर करना. ठीक है. थैंक यू.